the lesson.
Thank you, Dada.
So, friends and colleagues, it's indeed an exciting session for us today, this evening, and we will be continuing our coronary artery disease chapter. And today we have two very experienced presenters with us who will be giving us further insights into acute coronary syndrome, namely non-ST segment elevation MI. And we also have with us a very expert professor from NICVD, a very good friend of National Heart Foundation, Professor Amol Chaudhary. And he will give us insights of what a student needs to learn about these chapters. So without further ado, I will request Dr. Smita Kanungo to tell us about acute coronary syndrome, mainly non-STMI. Smita Kanungo.
Yeah, thank you, madam. Respected moderator, expert panel, and teachers and dear students. Once again, a very good evening and I welcome you all to the presentation. Before going to our main presentation, I would like to give us a scenario. A 60 years gentleman having diabetic and hypertension, and we came to our emergency department with having a chest heaviness more than 20 minutes. Moreover, the pain was not subsided with repeated use of nitroglycerin. His physical examinations were unremarkable. So without going for any further investigation with this clinical scenario, our clinical diagnosis was acute coronary syndrome. So what is acute coronary syndrome? It's basically a spectrum of clinical manifestations due to presence of acute myocardial ischemia. And it includes ST segment elevation myocardial infarction, unstable angina, and non-ST segment elevation myocardial infarction. STEMI is a ECG-based diagnosis, and the clear difference between the non-STEMI and unstable angina is the troponin, as the cardiac biomarker. If it's raised, this term is non-STEMI, and if it's not, it is termed as unstable angina. Patient with a non-ST acute coronary syndrome usually tends to be older, having more cardiac risk, traditional cardiac risk factors like hypertension, diabetes, smoking, dyslipidemia, etc. Moreover, greater likelihood of having prior MI and revascularization procedures. So to diagnosis of acute coronary syndrome is mainly depends on the integrating information of a patient with history, initial ECG, and some laboratory test. Patient with acute coronary syndrome obviously present with chest pain. The pain usually resemble with the chronic coronary syndrome, but there are some characteristic point of the chest pain that indicated that the patient having acute coronary syndrome. And these are the patient may present with rest angina or angina with minimal exertion, usually lasting more than 10 minutes, at least for 20 minutes. New onset severe angina, which is classified according to the Canadian Cardiovascular Society, and the crescendo type of angina, that means that the angina which was previously diagnosed angina now become more frequent, more severe, and precipitated by less severe degree of exertion. With accompanying with the chest pain, patient may present with nausea, dyspnea, or syncope. Sometimes patient may have some atypical manifestation or anginal equivalent. Patient with older age, women, and having diabetes or chronic kidney disease are more prone to present with this type of presentations. Some patients may have the features of precipitating causes like anemia, infection, fever, or metabolic or endocrinologic disorder. Patients with acute coronary syndrome usually physical examination resembles unremarkable. Sometimes may present with features of cardiogenic shock and heart failure. So any patient with acute chest pain, beside acute coronary syndrome, we have to keep in mind some differentials like pericarditis, heart failure, aortic dissection, aortic valve stenosis, pulmonary embolism, etc. And to differentiate these causes from acute coronary syndrome, we need to do some investigations. Among the investigations, there are very important two investigations which have to do with immediately with the patient with the chest pain, which give us the clue about the acute coronary syndrome. Among them, one is ECG, another one is the cardiac biomarker. European Society of Cardiology guidelines recommend any patients with chest pain in the emergency department, an ECG should be carried out within 10 minutes of arrival. There may be a number of findings in the ECG. ECG may be normal. More than half of the acute coronary syndrome patient may present with normal ECG. There may also is ST segment depression or transient elevation. ST segment elevation may be present in the lead AVR or T wave inversion. Here are some ECG. These patients are admitted in our hospital. This is almost a normal ECG. And this is another patient ECG. Here you can see the Valence syndrome, T wave inversion. And this ECG shows a gross ST segment depression in the lateral leads. Moreover, it has ST segment elevation in lead AVR. This type of ECG actually reveals a poor outcome. Also, it assumes that this patient may have left main or triple vessel disease. Besides ECG, another important investigating tool is the cardiac biomarker, that is the high sensitivity cardiac troponin, which is mandatory in all patients with suspected non-ST ACS. If the cardiac troponin is elevated beyond 5 folds, it is clear-cut indicative of type 1 MI. If it's increased up to 3-fold, there may be possibility of other conditions. The ASC guideline recommends a rapid rule in and rule out algorithm with a 0 hour and 1 hour with blood sampling at 0 and 1 hour with a validated algorithm. And what is this the rule in and rule out algorithm? Any patient with suspected non-ST ACS, so we have to take 2 samples of blood. One is at presentation, another blood sample is going taken 1 after from the 1 hour apart. So if the 0 hour blood sample report came out very low, we can easily rule out the cardiac cause. But if it came moderately increased or highly high, then we don't need to do another further blood sample. The patient usually should be get admitted and it grouped into rule in. Now, what in between them? If the sample report is low and 0 hour and without any increasement in the next 1 hour sample, this kind of patient can also be ruled out. Another group of patients, if the first blood sample resembles low, but there is slightly increasing or decreasing number in the changing number of troponin in the at 1 hour patient, this patient should be observed or it should be ruled out, rule in and get admitted to our hospital. This is the cutoff assay specific. Every specific cutoff assay value has its own value, very low and low. So with the combination of ECG and troponin, we can easily rule in or rule out the patient suspected with the non-ST ACS. A normal ECG patient having any change in the troponin should be observed or get admission. Any patient normal ECG and continuous negative troponin level can be ruled out. If any patient with clinical suspicion is with negative troponin value, a third blood sample can be also carried out. There are a number of conditions where cardiac troponin can be elevated, among them heart failure, chronic kidney disease, aortic dissection, valvular heart disease, arrhythmias are important. And some more neurological conditions. And to differentiate between these, there are a number of investigations like creatine kinase myocardial ban, N-terminal pro-BNP and serum creatine eGFR. These two investigations have some prognostic information and they are class 2A recommendation. Complete blood count fasting, the sugar HbA1c, lipid profile are need to be carried out. Did any patient suspected with pulmonary embolism, DTMR can be carried out, and chest X-ray can give us some information to rule out the other differentials. Now, imaging. Among the imaging, we can carry down non-invasive and invasive imaging. The ESA guideline recommended echocardiogram to evaluate the regional and global LV function and to rule in or rule out the differentials. Like we can rule out the differentials of myocarditis, aortic dissection, or any pericardial effusion. Again, with patients with presenting cardiac arrest or hemodynamic instability of preserved cardiovascular origin, echocardiography is recommended. Any patient in absence of regional wall motion abnormality, to improve the diagnostic and prognostic value, trained echocardiography is another option. Stress tests, preferably with the imaging, is recommended in patients who have a normal ECG and the normal levels of cardiac troponin with no recurrence of chest pain. In this high risk criteria include if this echocardiography wall motion abnormality more than 2 segments are involved at a low dose of dopamine, they are categorized as high risk patients. Cardiac magnetic resonance can be done in patients to assess both perfusion and wall motion abnormalities, and it permits the detection of scar tissue and also to differentiate from recent infarction, also help to facilitate the differentials as patients with MI have fixed perfusion defect. Single photon emission usually useful for risk stratification, and a patient having a post-stress less than 35 ejection fraction or the stress-induced larger multiple perfusion defect usually categorized as a high risk criteria. Among the non-invasive imaging, the anatomical, ESC guideline also recommended the coronary computed topography angiography in patients when there is a low to intermediate of coronary artery disease, cardiac troponin or ECG are normal or inconclusive, or it can be used as an alternative to invasive coronary angiography to exclude acute coronary syndrome. Regarding the invasive strategy, high-risk patients should have coronary angiography to be performed with a plan for revascularization with PCI or CABG where indicated. Detailing of invasive strategy will be discussed in our next segment. There are number of risk assessment scores that integrate the clinical variables and finding in ECG and laboratory tests. Among these scores, TIMI and GRACE scores are the most systemic and widely tested approaches. TIMI, that means the thrombolysis in myocardial infarction. It has 7 variables: age, risk factors, prior coronary disease, age, it will be more than 65 years, prior aspirin intake, severe angina, chest pain with 24 hours, and elevated markers. Each variable carries out 1 point. So the greater the number, the greater the risk of 14 days of cardiac events in hospital. High risks actually include a 5/7 or 6/7. Another scoring is the GRACE, the Global Registry of Acute Coronary Syndrome. It is a multi-center registry, and it's important because it gives an idea about the probability of in-hospital death. Whereas in TIMI risk score, Philip class and serum creatine level were not included. In GRACE score, there are 8 parameters: patient's age, heart rate, systolic blood pressure, Philip class, creatinine level, cardiac arrest in admission, ST deviation, and elevated marker. Each parameter has some number of scoring system. It is a little bit complicated because it needs calculator to calculate the risk score. Again, the higher the risk of probability of death in hospital is increased. This is a figure nomogram showing a calculation of GRACE score. For example, if a patient have a Philip class 200 millimeter of systolic blood pressure, 100 beats per minute of heart rate, age 65, with a creatinine level of 1 and no other history of cardiac arrest and ST segment deviation. The sum of all this score is 196. And if it's 196, the patient may have a 16% risk of having in-hospital death. So this is the risk. Here is it 190 between the 196. So he may have a risk of 16% in-hospital death. And the ESC guideline recommended high-risk criteria include the diagnosis of non-STEMI, dynamic of presumably new ST segment changes, transient ST segment elevation, and the grace risk score of more than 140. So with this slide, I would like to conclude my presentation and thank you all for patience hearing, and thank you, organizer, for giving me the opportunity.
So thank you, Smita, as usual, great presentation. And without further ado, I would like to go to our second speaker, and then maybe we will have the discussion at the end and we will ask the opinions from our panel of experts. But I think Smita would like to leave before the end of the session. So Professor Amol, if you have any questions or if any of the other faculty have any questions, please kindly ask the questions now to Smita, because she might have to leave us before 9 o'clock. Smita, do you any questions for Smita, Professor Amol?
Thank you, ma'am. It's a very brilliant presentation. I usually expect from Smita. She is a very nice and brilliant presentation with new following the new guideline, which is published in the 2021 AC guideline as a non-STMI. Here, she also covered the scenario and all the rule out, ruling protocol also have been changed, little change. It was previously it was 0 hour, 3 hour, 0 hour, 2 hour. Now it is 0 hour, 1 hour, 2 hours is not mandatory, and 3 hours is mandatory. And if there is a strong suspicion still persists, and another sample can be sent up to 6 hours. This is, I think, ruling, and after ruling, there is some change also coming. As Smita shows that there is some change in the terminology, like very high risk, intermediate risks have been obsolete from the non-STMI. Intermediate risks. Very high risk now, very high risk and low risk. Intermediate risk have been obsoleted, and invasive strategy also, I think Rahiduzzaman sir will expect that after that I will discuss the invasive treatment strategy. And now nomenclature also some change, non-Nste-Acs and Nste-Acs. There is also before there is non-Nste-Acs include non-STMI and unstable angina. But nowadays the direct clean cut non-Nste-Acs and Nste-Acs have divided, and there is also all address the non-Nste-Acs is the mortality and morbidity is equal or sometimes more than the ST elevation ACS. Thank you, ma'am. Thank you, brilliant presentation. We can expect the Rahiduzzaman lecture, then we again discuss
yes, absolutely. Thank you. So Professor Rahiduzzaman requires no introduction. He is one of the most senior professors of National Heart Foundation Hospital and Research Institute, and he is a great scholar and a very brilliant speaker. And I hope and I expect that we all will be learning a lot about the management of non-ST segment elevation acute coronary syndrome from him. Without further ado, Professor Rahiduzzaman, yes, শোনা যাচ্ছে জি
আর স্ক্রিন শেয়ার হয়েছে
স্ক্রিন শেয়ার সাইডে কি হচ্ছে আবার শেয়ার করা মানে যে সাইডেরটাও দেখা যাচ্ছে আপনি শেয়ারে ক্লিক দিলে পুরাটা চলে আসবে এখন জি এখন দেখা যাচ্ছে
থ্যাংক ইউ ভেরি মাচ ওকে
ম্যাডাম স্মিতা চলে গেছে ম্যাডাম
স্মিতা 9টায় যাবে 9টায়
Awesome. Thank you. Thank you, madam. Can I ask a simple question to Smita, madam?
Yes, please go ahead.
Smita,
Sir. Sir,
তো
Hello, hello.
মিউট হয়ে
স্মিতা?
গেল তো হ্যাঁ
স্যার
বলো
শুনতে পাচ্ছি স্যার প্লিজ
আই থিংক
স্যার হ্যাঁ
আচ্ছা পরে এটা আলোচনা করলে মনে হয় ভালো হবে নাকি?
so actually I'm sure one of us will answer on behalf of Smita and we can ask her
Thank you.
tomorrow also because
Smita?
hey just okay Smita,
স্যার শুনতে পাচ্ছি আমি প্রশ্নটা
Smita শোনা
Probably.
যাচ্ছে, we can't hear the question sir
হ্যাঁ,
The
স্মিতা
question- হ্যাঁ
শোনা যাচ্ছে স্মিতা?
না
স্যার ইস ইন্টারাপ্ট ভেঙে
স্যার
আসছে
কোশ্চেনটা পরেই করো আজকে এখন তুমি আর ইন্টারাপ্টেড বাই নেটওয়ার্ক তুমি একটু পরেই করো তাহলে কোশ্চেনটা
ইন্টারনেট স্লো মনে হয় নেসারের বাসায় Nessa, we can't listen to your question. We just hear Smita and then it's a blank. So we'll
আই থিংক আমি স্টার্ট করি
so please Professor.
Okay, good evening, everyone. Today, my topic of discussion is management of non-Nste-Acs. My presentation will be based solely on 2020 ESC guideline. And before I start presenting, I just want to mention that this presentation is going to be a bit longer than usual. So please have patience, and I thank you all in advance because please have patience because it's a long presentation. It includes information which is very important for all the students, fellows working in emergency department, CCU, wards, and cath lab. So first of all, when a patient with chest pain comes to emergency department, this patient should be put on continuous rhythm monitoring until the diagnosis has been established or ruled out. Look at it, it's a class 1 indication. And this rhythm monitoring should be maintained up to 24 hours or up to PCI, which will come first in patient who are at low risk of arrhythmia. But if the patient is at a very high risk of arrhythmia, this rhythm monitoring should be continued beyond 24 hours. Now, as we all know, high sensitivity troponin are used mainly for diagnosing non-STMI, but beyond its diagnostic role, it is also recommended to measure troponin I serially for estimation of prognosis and in class 1 indication, and also measuring BNP and non-NT-proBNP should be considered to gain prognostic information. Now, as Dr. Smita has mentioned, risk stratification is very important to plan the strategy of treatment. And among all the risk score, GRACE risk score has been suggested for estimating prognosis. Previously, TIMI risk score was also included, but this new guideline has included only GRACE risk score model to estimate prognosis. And also we should estimate bleeding risk and use this score for patient undergoing coronary angiography. So how we calculate GRACE risk score? All the smartphone contains the GRACE risk score app. Just click on it and there will be a page open and there are the variables as Dr. Smita has mentioned. Just put in the variables and just click calculate and the risk score will come. It's so simple. So you can do it with your smartphone. And this risk score is very important for planning strategy, especially planning invasive strategy in patient with non-Nste-Acs. Look at this, is very busy slide, I'm sorry, but these are the major and minor criteria for bleeding risk assessment. I will not go through all the points, but I will mention few points which are very common we encounter in our cath lab. There are major criteria like severe or end-stage CKD, that is GFR less than 30, hemoglobin less than 11, platelet less than 100, patient with previous intracranial hemorrhage, and patient with moderate to severe ischemic stroke. And there are some minor factors like age 75 or more, moderate CKD, and hemoglobin in man 11 to less than 13, and in women 11 to less than 12. So if a patient has any one of these major risk factor or any two of these minor risk factor, he is at high bleeding risk. Now, the management is a general management and pharmacological management. As we'll know, general management includes lifestyle modification. I will not discuss in details this slide because this has already been discussed in our previous lecture on chronic coronary syndrome. And but just to mention that, look at these slides. All are class 1 indication. Well, what is the? These are all the intervention need to maintain lifestyle modification. These are all highly recommended. Only I want to mention here, annual influenza vaccination is now class 1 indication. Annual influenza vaccination is recommended in patients with coronary artery disease, especially in older patients, in order to improve morbidity. So this has a new idea. Now the pharmacological treatment is antithrombotic and antiplatelet treatment and other anti-ischemic therapy like lipid lowering, beta blocker, ARB, MRS, nitrates, etc. I will mainly focus on antithrombotic and antiplatelet treatment, but I will briefly discuss others also. Regarding lipid lowering drugs, we all know statins are recommended in all patients, and aim is to reduce LDL by 50% or more from the baseline or below 55. And if this goal is not achieved, we should add ezetimibe. And still, if it's not achieved, we can add PCSK9 inhibitors. Regarding ACI ARBs, it is used mainly in patients with reduced LVEF, patients with diabetes, and patients with CKD, unless contraindicated. Beta blocker also used in patients with LV dysfunction, and it should be used in long term to reduce all-cause cardiovascular and cardiovascular morbidity and mortality. Regarding MRS, mineralocorticoid antagonist, is used in patients with reduced ejection fraction, and proton pump inhibitor used in patients with very high risk of gastrointestinal bleeding. Regarding nitrate and beta blocker, especially in acute phase, it is used, may be used in sublingual or IV in patients with ongoing ischemic symptom, and also we should continue chronic beta blocker therapy unless contraindicated. But in a patient with suspected or confirmed vasospastic angina, calcium channel blocker and nitrate should be used, and beta blocker should be avoided. Now the main topic is antithrombotics and antiplatelets. So what are the drugs? There are some anticoagulant drugs and there are some antiplatelet drugs. Among the anticoagulant drugs, there are vitamin K inhibitor, which inhibits a coagulant cascade. There is factor 10 inhibitors. There are thrombin inhibitors. And among the antiplatelet are aspirins, the clopidogrel, prasugrel, and ticagrelor, and GP2B3 inhibitors. Now, just a comparison between the drugs available. Regarding the reversibility, we know that ticagrelor is the only drug which is reversible, and regarding bioactivation, ticagrelor doesn't need bioactivation. And regarding the onset of action, ticagrelor is most rapid onset of action. And regarding delay to surgery, 5 to 7 days is required before surgery. We should stop these drugs 5 to 7 days prior to surgery. Unfortunately, no dose adjustment is needed in any of these drugs in kidney failure. Now, before you start antiplatelet antithrombotic therapy, we should assess ischemic risk and bleeding risk. How can we assess it? The choice of drug dosing, and treatment duration by patient characteristic like age, sex, race, clinical presentation like CCS versus ACS, comorbidities like CKD, diabetes, peripheral artery disease, co-medications like patients who are already on anticoagulation, and procedural aspect like PCI versus CABG, femoral versus radial access, invasive versus conservative management. So considering all these factors, we should balance the ischemic and bleeding risk. And after that, we should start the antithrombotic or antiplatelet treatment. Now, we all know aspirin is recommended for all patients without contraindication with initial dose of loading dose of 150 to 300 and maintenance dose of 75 to 100. Next, a P2Y12 receptor is recommended in addition to aspirin, and it should be maintained over 12 months unless contraindicated. But which P2Y12 receptor should we use? The options are, number one, prasugrel. Just look at it. Prasugrel is specifically indicated for patient who is undergoing PCI. Next is ticagrelor, irrespective of treatment strategy, either conservative or invasive, we can continue ticagrelor with aspirin. And regarding clopidogrel, just is say that only when prasugrel, ticagrelor are not available or cannot be tolerated or contraindicated. So initial choice should be prasugrel and ticagrelor. And prasugrel should be considered in preference to ticagrelor in patients with non-Nste-Acs who are proceeding to PCI. So a patient who are going to a cath lab for PCI, we should reload the patient with prasugrel, not ticagrelor. Now, there's an interesting point here. If a patient comes to emergency room with very high risk non-STMI, and I am planning very early invasive therapy with less than 2 hours, this patient should not be preloaded with P2Y2 receptor blocker. It is contraindicated. In patient in home, coronary anatomy is not known, and early invasive is planned. It is not recommended to load this patient with P2Y2 receptor. But if the early invasive therapy study is not planned and patient doesn't have a high bleeding risk, you can preload this patient with P2Y12 receptor blocker. This is a new concept. I think in previous guideline, this was not present like this. Regarding parenteral anticoagulation, we know it should use parenteral anticoagulation during diagnosis, especially during resuscitation procedure. And unfractionated heparin is a drug of choice, and ACT should be maintained at 250 to 350 or 200 to 250 if you are using a 2B3A receptor inhibitor along with heparin. Now, an interesting aspect is that if the patient is not planning for an intervention or patient cannot reach a PCI center in a required time frame, fondaparinux is recommended as a class 1 indication. And when this patient goes to cath lab, a single bolus dose of unfractionated heparin is recommended at the time of PCI. But if the patient is already getting enoxaparin, this patient should be given IV enoxaparin during PCI rather than unfractionated heparin. This is also a new idea. You see, bivalirudin is an alternative drug, but the indication has been downgraded to 2B. And crossover of unfractionated heparin and low molecular heparin is not recommended. What does it mean actually? It means that if a patient is receiving a low molecular weight heparin before coming to cath lab, this patient should not be given unfractionated heparin during PCI, except for fondaparinux. Patient receiving fondaparinux can be given unfractionated heparin, but patient receiving enoxaparin or any other low molecular weight heparin should not be given unfractionated heparin during PCI or revascularization. This is a very new concept, very controversial concept. I don't know whether this is going to change our daily practice. Now, we all know GFPD should be recommended and should be continued for about 12 months if there is no contraindication. But sometimes we need to prolong antithrombotic treatment beyond 12 months when the patient is with high risk of ischemic events without increased risk of life-threatening bleeding. Now, how can we prolong? Again, there is a very interesting concept here. I just want to explain it. Now, a patient who has come to a cath lab and you have done a PCI, now patient has gone to the ward or CCU. You have stopped parenteral anticoagulation. You have started aspirin and clopidogrel. Now you can add a third agent, low dose rivaroxaban, 2.5 milligram BID, approximately for 1 year, along with aspirin and clopidogrel. It's also a new idea which has come into this guideline. It's still a 2B recommendation, but this is quite highlighted in the whole of the guideline. Now, sometimes we need to shorten antithrombotic drug. When there is a very high risk, high bleeding risk, we should continue P2Y12 receptor inhibitor therapy after 3 months. Or we can stop aspirin after 3 to 6 months and continue only P2Y12 receptor blocker. Sometimes we need to de-escalate P2Y12 receptor. For example, switching from prasugrel to ticagrelor to clopidogrel. In that case, this de-escalation may be done unguided based on clinical judgment or guided by platelet function testing. This is in summary. I just want to mention here. First of all, anticoagulation for PCI. Unfractionated heparin is class 1, enoxaparin class 2, and bivalent class 2B. You assess the bleeding risk. In low bleeding risk patient, there are two options. Option number 1, use aspirin with either prasugrel, ticagrelor, or clopidogrel for 12 months. And then aspirin and rivaroxaban beyond 12 months, or aspirin with other beyond 12 months. Next option is use aspirin with ticagrelor with 3 months and then ticagrelor alone beyond 12 months. If patient is very high risk, use clopidogrel and aspirin for 3 months and then aspirin alone. And in very high risk patient, aspirin and clopidogrel for 1 month and clopidogrel alone. So this is a new concept using aspirin and rivaroxaban beyond 12 months in a patient undergoing PCI. So how to choose a second agent along with aspirin for extending treatment? As I mentioned, rivaroxaban is mainly used in patients with symptomatic coronary artery disease and also symptomatic peripheral artery disease. And clopidogrel is used in patients with post-MI patient. Prasugrel is used mainly in post-PCI patient. And ticagrelor is used both in post-PCI and post-MI patient. So which group of patient needs DAPT to be extended beyond 12 months or even 24 months and sometimes even 36 months? So these are the patients who are at very high thrombotic risk. These are the risk factor. There are some risk enhancer like patient with diabetes requiring medication, history of recurrent MI, any multifacetal coronary artery disease, patient with both coronary artery disease and peripheral vascular disease, patient with premature or accelerated coronary artery disease, concomitant systemic inflammatory disease like HIV, SLE, and CKD 15 to 59. Technical aspect, patient receiving at least 3 stents, at least 3 lesions treated, total stent length more than 60 millimeter, complex revascularization like left main bifurcation stenting with 2 or more stents, CTOs, and especially stenting of the last patent vessel, and history of stent thrombosis despite having antiplatelet. So any patient with complex coronary artery disease with any one of these features should be continued DAPT beyond 12 months, even beyond 24, even up to 36 months. So how can we reduce bleeding risk during PCI? We should adjust anticoagulant dose to body weight and renal function, especially in women and older patients. And radial approach should be the default vascular access. And proton pump inhibitor should be given in a patient with at higher than average risk of GI bleeding, like age 65 and above, dyspepsia, patient with GI reflux disease, patient with Helicobacter infection, and patient with chronic alcohol use. Now, important factor, a patient who is already on oral anticoagulant for whatever reason, either due to atrial fibrillation or due to mechanical valve replacement, now patient is undergoing PCI, what to do? This patient, PCI should be performed without interruption of antagonist or NOAC. But if the INR is more than 2 and 2.5, you don't need to administer extra unfractionated heparin. And in the patient with NOAC, regardless of the timing of the last administration of NOAC, we should add low dose parenteral anticoagulation, either enoxaparin or unfractionated heparin. Aspirin is indicated, but pre-treatment with P2Y2 receptor inhibitor is not indicated. And use 2B3 receptor blocker only in bailout and very complicated situation. So this is the flow chart. A patient already on anticoagulant. The default strategy is use triple therapy, oral anticoagulant plus DAPT for 1 week in the hospital. Outside the hospital, it is double anticoagulant, double therapy, oral anticoagulant, and single antiplatelet for 12 months. And a very high bleeding risk patient should, very high risk patient should go for double therapy for 6 months, then only oral anticoagulant for 12 months. And high ischemic risk patient, triple therapy should be continued 1 month and double therapy after 12 months. Another interesting point is, this is also a very new concept. All these patients who are on anticoagulant, after 12 months, patients should receive only anticoagulant, no aspirin, no clopidogrel, no ticagrelor, nothing else. So even after PCI, A patient receiving anticoagulant should be kept only on anticoagulant beyond 12 months. This is also a new concept in this guideline. Now the invasive therapy in patient with non-ST-SCS. Time of strategy, immediate invasive strategy, that is within less than 2 hours, is recommended in patients who have any one of the following criteria: hemodynamic instability or cardiogenic shock, recurrent or refractory chest pain despite medical treatment, life-threatening arrhythmia, mechanical complication of MI, heart failure clearly related to non-ST-MI, and presence of ST segment depression of more than 1 millimeter in 6 or more leads, in addition to ST elevation in AVR and or V1. So if the patient comes to emergency room with any one of these criteria, patient should be arranged for immediate invasive strategy in less than 2 hours. And this patient should not be given loading dose of P2 vital receptor blocker. And early invasive strategy, that is within 24 hours, recommended in any patient with following criteria: that is diagnosis of non-ST-MI, dynamic or presumably new contiguous ST segment changes, and transient ST segment elevation, and GRACE score more than 140. Just look at it. Simply having the diagnosis of non-ST-MI enable just simply having the diagnosis of ST-MI, the patient need an early invasive strategy within 24 hours, despite any other thing. So wherever a patient comes to our hospital or in the ward with non-ST elevation MI, we should try to arrange an early invasive strategy for this patient. But for all other patients, selective invasive strategy should be adapted. We should do appropriate ischemia testing, and then we should go for further planning. There are some technical aspects. Radial access again recommended, and DES is recommended over Biomarker for any other condition. Technical condition, revascularization strategy, that is ad hoc culprit lesion PCI or multivessel PCI CABG, should be based on patient's clinical status, comorbidities, and disease severity. But decision on immediate PCI of the culprit stenosis doesn't require heart team consultation. And again, complete revascularization should be considered in non-STS patient without cardiogenic shock with multivessel coronary. So this is the same thing. Now, patient with heart failure and non-STS or patient with cardiogenic shock. Patient who comes with heart failure and cardiogenic shock, emergency coronary angiogram is recorded, emergency PCI of culprit lesion, independent of the time delay of symptom. That's important. Independent of time delay of symptom onset. Emergency CABG if the anatomy is not amenable to PCI. Emergency echocardiography to assess LV and valvular function, exclude mechanical complication. And emergency surgical and catheter-based repair of mechanical complication of SCS. These are all class 1 indication in patient with non-ST elevation MI with cardiogenic shock. Interestingly, routine use of IBP in patient with cardiogenic shock, but no mechanical complication is not recommended. But routine use of immediate, again, also patient with non-ST-MI and cardiogenic shock, total revascularization is not recommended. But if the patient is in shock due to mechanical complication, you can use IBP. Regarding diabetes mellitus, all patients with non-ST-SCS should be monitored for diabetes frequently. Hypoglycemia should be avoided, and if glucose level is more than 10 millimole per liter, a glucose lowering therapy should be considered. Regarding CKD, management of CKD patient with non-ST-MI is similar as the non-CKD patient, but please assess kidney function of all patients by eGFR, not by serum creatinine. Regarding a CKD patient undergoing revascularization, use low and isoosmolar contrast media as lowest volume possible, and pre and post hydration should be done if the expected contrast volume is more than 100 ml. Another interesting piece of information here. CABG should be considered over PCI in a patient with multivessel coronary artery disease whose surgical risk profile is acceptable and life expectancy is more than 1 year. Class 2 and 2. That is a patient with chronic kidney disease who has multivessel disease and his surgical risk profile is acceptable. His life expectancy is more than 1 year. This patient should be sent for CABG rather than PCI. This is also a new addition to this guideline and this last two indication. Patient with older patient studies are similar as the diagnostic studies and intervention studies are similar as younger patient. Only that we should choose antithrombotic agent and dose should be measured according to the renal function and other important indications. There are two new inclusion in ACS. One is MINOCA and one is SCAD. MINOCA, migraine infarction with non-obstructive coronary artery disease, and SCAD, spontaneous coronary artery dissection. This section has been included in current guideline. So what is MINOCA? You diagnose AMI either by fourth universal definition, and there are some clinical evidence like symptoms of migraine ischemia, new ECG changes, development of pathological Q wave, imaging evidence of wall motion abnormality, and identification of coronary thrombus. After diagnosing MI, confirming, do angiogram and you see non-obstructive coronary artery. What does it mean? It does mean that there is no coronary artery stenosis 50% more in any of the major epicardial vessel, which includes normal artery, mild nummular irregularities, or moderate stenosis more than 30 but less than 50. And number three, no specific alternate diagnosis is available. So all these three will lead to the diagnosis of MINOCA. So what to do with MINOCA? Recommendation is we should do initial working diagnosis should be follow the diagnostic algorithm to differentiate true MINOCA from alternative diagnosis. We should perform CMR in all patients with MINOCA without an obvious reason. And it is recommended to treat the patient according to the disease-specific guideline. This is spontaneous coronary artery dissection, angiographically suspected. Type 1 is multiple radial syndrome, which is obstructive with reduced coronary flow, should go for CABG or surgery, PCI. Type 2, long diffuse smooth stenosis, there is obstructive but normal coronary flow. We should go for intracoronary imaging. And patient type 3, focal and tubular non-obstructive. In both type 2 and type 3, we should optimize the medical therapy and wait for spontaneous healing. But even after this, if the risk anatomy is high risk and there is persistent and recurrent angina, patient should be treated as obstructive coronary artery disease. If not, patient should be considered for CT angiogram. So what is new? Number one, the name is new. The non-STMI has changed into non-STACS. And next, measurement of BNP and proBNP has been added. Prasugal has given preference over ticagrelor in non-STMI patient who proceed to PCI. And again, discontinuation of antiplatelet therapy in patients who are on oral anticoagulant agent after 12 months. This was a new thing. And another important thing is that simply diagnosis of a non-STMI will enable the patient to go for an early intervention strategy. Dynamic change, I have already mentioned it. And complete revascularization should be considered in patient without cardiogenic shock and multivessel disease. Just mention, if this patient has cardiogenic shock, it is coronary event. But if there is no cardiogenic shock, you can go for a complete revascularization. And if you are guided complete guided revascularization of non-culprit lesion is also recommended. Bivalirudin has been downgraded from class 1 to class 2B. And again, to summarize, just I don't want to mention this topic because they already discussed. Only for revascularization modalities, favors PCI, single vessel disease and clinical instability, favors CABG, diabetes with complex multivessel disease with early dysfunction. And regarding the choice of antithrombotic agent, aspirin, unfractionated heparin, and fondaparinux is in a class 1, enoxaparin class 2, and bivalirudin class 2B. And about the second agent, prasugrel, ticagrelor, or clopidogrel should be used. Blood pressure should be controlled, diabetes control, diabetes manifestation is there. With that, I want to thank you all. Thank you very much for your patience hearing. Thank you very much.
So thank you. That was a very comprehensive discussion on a very interesting subject. And as you said, the terminology has also been changed. So without further ado, I'm sure all our audience are buzzing with questions. So I would ask our faculty to ask questions, and also our attendees, if they have any questions, to put it in the chat box. Any questions? Like Nesar had a question. Nesar, do you want to ask this question to Professor Rahiduzzaman?
Nesar, কোথায়?
Any other questions from our panel of experts or our guest, Professor Amol? Do you have any comments, questions, or any insights for our students? That was a great lecture, by the way, Professor Rahiduzzaman. We
Thank you
all
very much,
learned such a lot from you, and it was very clear, very articulate, and I'm sure the students will really benefit from this very lucid lecture that you presented to us. You made it very clear for us to understand. Thank you.
Thank you very much, madam.
Thank you, madam. I think Rahiduzzaman, Dr. Rahiduzzaman give a lecture of very, you have already mentioned, very comprehensive, but palatable, very comprehensive, and all pros and cons of new guideline he has elevated to show us what are the new things and what are the older things, or new nomenclature and everything. And I like to ask the question or your experience about the use of high potency antiplatelet, particularly pasuquinol and ticagrelor in the setting of ACS, and which one is you prefer? I think that I have an 7 or 8 year experience of ticagrelor used for the last 7 years. We have done also papers on ticagrelor and clopidogrel comparison in non-ACS patient, including STEMI and non-ACS. But all of you know, ICERIAC trial, 5 trial shows that some superiority of mass and MI and cardiovascular event is in favor of pasuquinol than ticagrelor. I like to know from Rahiduzzaman, what is the actual position of pasuquinol in this setting? Like one is the, if we went to conservative management of non-ACS, in the having high risks or very high risks, sometimes we need to adopt conservative attitude. At that scenario, and one scenario, if we did angiogram and contemplated, intended to PCI, but we did not do PCI due to unfavorable anatomy. What will be the position of ticagrelor and pasuquinol?
Thank you, Professor Amol. Actually, it's said very clearly said in the guideline. The pasuquinol is only indicated over all other drugs, only when the patient is proceeding for PCI. For medical management patient, conservative management patient, no, ticagrelor should be used. So only when a patient is planned for PCI, pasuquinol is preferred over ticagrelor. And clopidogrel has been downgraded. You see, it's written that clopidogrel should be used only when ticagrelor and pasuquinol is not available, not tolerated, or there's a contraindication. Otherwise, clopidogrel should not be used. In our scenario, due to expense of the ticagrelor, most of the patients cannot afford ticagrelor for a long time. And pasuquinol, I'm using pasuquinol for last maybe 5 to 6 years. More than that, 5 to 6 years, I don't find too much of complication with pasuquinol. A couple of patients comes with spontaneous chymosis or skin color discoloration, but otherwise pasuquinol is quite a safe drug if you just maintain one thing. Number one, age of the patient, weight of the patient, serum creatinine, kidney function. These three things you should maintain. If a weight is less than 60 and age is 75 and above, give 5 milligram instead of say 10 milligram. That will suffice. So if your patient has undergone PCI, it is better to continue basic pasuquinol if there is no strong contraindication. And regarding ticagrelor, even if the patient is has not undergone PCI, you can use ticagrelor as a second agent for 12 months or more.
না বলতে আমি বলতে যাচ্ছি যে তাহলে pasuquinol যে superiority হলো, এটা ইউজ করতে মানে আমাদের তো খুব একটা স্মল গ্রুপ পড়ে যাচ্ছে যে আমরা পিসিআই করলেই শুধু ইউজ করতে পারবো,
এক্স্যাক্টলি, শুধু পিসিআই করলে
করতে পারবো না। তাহলে কি পার্সোগ্রালের লোডিং ডোজটা ক্যাথল্যাবে পিসিআই করা ঠিক করে তারপরে লোডিং ডোজটা দিব?
এক্স্যাক্টলি, এই কথাই এখানে প্রশ্ন আসছে যে কোশ্চেন আসছে কেন একটা পেশেন্টকে যদি আমরা আর্লি ইনভেসিভ থেরাপিতে যাই কেন আমরা লোডিং দেবো না। এটা ইন ডিটেলস লিটারেচার লেখা আছে, তারা বলছে যে ইট উইল ইনক্রিজ দ্য ব্লিডিং রিস্ক। কারণ ইফ সাপোজ আমি অ্যাঞ্জিওগ্রাম করলাম, the patient is not amenable to PCI, patient needs some other, তখন তার বলছে because these antiplatelets drugs are so potent and so rapid action, so why not we wait and do an angiogram, and then if you want to do PCI, just give the loading dose just before PCI. That's something. Don't do it to give it 2 or 3 hours back. That's what they say.
Only aspirin will be the loading dose, huh?
শুধু অ্যাসপিরিন দিতে বলেছে। কিন্তু যদি এমন হয় যে আমরা ইনভেসিভ থেরাপিটাকে ডিলে করছি বিকজ পিসিআই সেন্টার না এটা, in that case you can give loading dose of clopidogrel or ticagrelor or prasugrel.
No, at that time we shift to the
Ticagrelor, yes.
Okay.
Or clopidogrel.
If there is doubt about the invasive procedure.
Exactly.
Or we deal. Number two, you express your experience in favor of pasugrel, but when this isolated trial published, I start the pasugrel. My experience, one of my patient developed 10 milligram pasugrel after PCI, huge intracranial hemorrhage. But for the last 7 years, I did not get any intracranial hemorrhage. Only I faced some bruise or some dental gum bleeding and
minor
some unexplained dyspnea. Even then, some syncopal history I got due to ventricular pause, and even then some uric acid elevation. We made very non-significant statistically. We faced the unexplained dyspnea. I faced the ventricular pause, and some patient told us, sir, I feel vertigo and blackout sometimes after getting this done, and some uric acid elevation. But no major life-threatening hemorrhage have been happened by ticagrelor in my patient for the last 7 years. But in pasugrel, I start use very hopefully after publishing the Acute-5 trial, but I think 1 month or 2 months I got a massive intracranial hemorrhage. So again I choose our to.
Fortunately, my experience with pasugrel is quite good. So I'm using all patients who are undergoing PCI. I'm using pasugrel in very heavily all patients unless patient is very old, patient is very frail, or patient kidney function is very low. Otherwise, I'm using pasugrel for all patients who are undergoing PCI. Especially patient you are doing a left-main bifurcation, you are doing multivessel, or you are doing some complicated cases. Pasugrel definitely prefer over ticagrelor.
About this, I wanted to ask you a question from your vast experience. Number one is, do you go on continuing the prasugrel for the entire like 1 year, or do you, like some studies have shown that after the 1 month, because the thrombotic risk is the highest in the 1 month, so after 1 month, do you switch to a cheaper and a more safer?
Actually, thank you, madam. Yeah, yes. That's a very good question. Actually, I talk with the patient after he comes 1 month, so whether he can go for pasugrel because the price is higher than clopidogrel. If the patient says that yes, I'm okay with the price, there's no problem, I can afford it, then I continue it for 1 year. If sometimes patient comes and said, please change the drug because it's expensive and it's not available in my area, in that case, I change to clopidogrel. Otherwise, if the patient can afford it, patient can tolerate it, there's no complication, I use it up to 1 year. After 1 year, I de-escalate to clopidogrel. And this is what is written also in the present guideline, to continue it up to 12 months.
Another question. So like in Japan, they even have 3.125 of prasugrel, right?
Yeah.
They're using it. And they say that like in Korea, like they're giving lower dose of ticagrelor, lower dose of prasugrel, and they're saying that this is very effective. Now in Bangladesh, we have not unfortunately done any study, but I think our people are in some aspects pretty prone to, bruising and all, and they get very upset about this. So do you feel that there is a role for low dose prasugrel?
I
5
use
milligram?
I use
Even-
5 milligram. I
Even
use 5 milligram prasugrel.
yes, so
sometimes.
even not for elderly people or those with CKD or those with previous problems, but normal persons, do you use 5 milligrams for them as well?
Yeah, I sometimes use after so if I want to continue after 1 year, I shift to 5 milligram. If I want to continue prasugrel beyond 12 months, I shift to it.
Brother John, there is a trial between 60 milligram ticagrelor and 90 milligram ticagrelor. There is the event that prevention is same. But as far as I know, there is no study between 5 milligram and 10 milligram prasugrel right now to prevent the cardiovascular event. Except 70 older, more than 70 years and 60 kg, less than 60 kg. এরকম তো কোনো স্টাডি নাই বুঝছেন ভাই
এরকম স্টাডি নাই বাট বলা আছে তুমি যদি if you go through the literature of guideline it said that you can give 5 milligram prasugrel if you think it is feasible for the patient after 12 months of because after 12 months is highly recommended in low risk patient but after 12 months you can choose according to your own choice.
Questions from the faculty?
Madam, I have one
Yes,
query
please.
regarding the use. Yes, I have one query to Rahiduzzaman sir. Thank you, sir. Very elaborate lecture and very new things. And sometimes the things last 10-15 years we are doing with clopidogrel or prasugrel or ticagrelor loading. Then we are taking the patient to the cath lab. Now the consensus is like this: only you will give aspirin, then you will take the patient to the cath lab. If the patient need immediate PCI, then loading dose of ticagrelor or prasugrel that will take at least few hours to
It takes only loading dose takes only 30 minutes to act.
Only ticagrelor.
No, only prasugrel also takes 30 minutes. 30 minutes.
30 minutes.
If you load it, if we give loading dose, it gets 30 minutes to take action. And that is written clearly in the guideline that because we have not very potent antiplatelet drug, we don't need to give it earlier. Just give it before PCI.
Then we have to wait for 30 minutes before putting the wire in the
আমরা কিন্তু যখন অনেক সময় অ্যাড হক পিসিআই যখন করি পেশেন্ট যদি ধর ফর টাইট লেফটম্যান ডিজিজ বা আমার তখন পেশেন্টকে তাৎক্ষণিকভাবে কিন্তু লোডিং ডোজ খাওয়াই দিই আজাদ ক্লোপিডগ্রেল আর টিকাগ্রেল, ঠিক আছে? এবং এটা কিন্তু এখন তাদের কনসেনসাস এটাই যে এটা করলেই বেটার বিকজ ইট উইল রিডিউস দ্য ব্লিডিং রিস্ক। They are more concerned about a bleeding risk. আমি যত পুরোটা পড়ে দেখলাম, they are very much concerned about bleeding risk of the patient. So they are doing everything they can do to reduce the bleeding risk in patient who are undergoing PCI.
Sometimes we have seen that we are more concerned with stent thrombosis, coronary thrombosis, like this, because slow flow, especially in acute coronary syndrome.
So
if we
for all practical purpose, let me say, for all practical purpose, in our country, we have to give loading dose to every patient because we cannot arrange invasive therapy within 2 hours in all patients with Nste-Acs-Nhf. It is only recommended for patients for whom we can arrange invasive therapy within less than 2 hours. So practically, it is not feasible in our country. We cannot arrange invasive therapy within less than 2 hours. So we have to give loading dose to all patients and wait for the invasive therapy maybe 1 or 2 days later. So it is just for information, but for all practical purpose, I don't think this is feasible in our country. Madam,
Any further questions from? Yeah, of course. Are there any questions? Panel of experts, Professor Neste, you were very keen to ask something. We would be very happy to hear what that is. Professor Neste?
Neste is not available.
Okay, Ashok has already made his comments. Dr. Habibur Rahman, any comments from you? So, Amol, any concluding remarks?
This is the MD student class, madam. So for the
Yes.
MD student, till now this conception is not up to date, most of the examiners. So what they will do in the exam hall, because they will invariably ask a non-ST patient in emergency, how will you manage it? What should be their strategy, or how they will approach to that patient? So that may make them confused.
They will say the old one. They will give the loading dose. If the examiner asks the examiner, is there any newer concept about it? Then he can say, yes, there is some newer concept about it. Otherwise, he will say the old-fashioned thing. And if there is a leading question from the examiner, then he can say, okay, so yes, there is some new concept, new guideline, and this is the concept. So that's the way the
that is intelligent answer. That should be intelligent.
পরীক্ষাতে এটা বাধা হয়ে দাঁড়াবে না, একটু গ্যারান্টি দেওয়া যেতে পারে। পরীক্ষাতে এটা বাধা হয়ে দাঁড়াবে না, তারা মুখ খুলতে পারলেই হলো। তারা তো পুরাতন লোডিং ডোজই ঠিক মতো বলতে পারে না। নতুন লোডিং ডোজের যে বদুজন লোডিং ডোজ বললে একটা যদি ইন্টারচেঞ্জ বলি, how you interchange antiplatelet or potency, এটাই বলতে পারে না। বেসিক জিনিসটা আগে জিজ্ঞাসা করতে হবে, তারপরে না বলতে হবে you can do a new concept। এবং এটা বদুজ্জামান ভাই যেটা বলেছে যে বদুজ্জামান ভাইয়ের কাছে পড়ে মনে হচ্ছে যে it is the building risk factor not to use Pasugrel before contemplated to PCI। আমার কাছে মনে হচ্ছে যে এই ফেভারেবল অ্যানাটমি আর আনফেভারেবল অ্যানাটমি জানাটাই ইম্পর্টেন্ট রাদার দ্যান ব্লিডিং রিস্ক। কারণ এই পেশেন্ট তো তার ব্লিডিং হতেই পারে, মানে তার তো থ্রম্বাস, তার তো ইম্পর্টেন্ট অ্যান্টিপ্লেটলেট তার প্রাপ্য, কিন্তু আমরা তাকে বিরত করছি একটা মাত্র 300 মিলিগ্রাম অ্যাসপিরিন দিয়ে। এই জায়গায় আমার কাছে আমি পড়ে মনে আছে এই নতুন গাইডলাইন যে করোনারি অ্যানাটমি ইজ ফেভারেবল ফর পিসিআই or CBG, because if it is table to table CBG done, then it is very difficult to overcome the loading dose in the same activity. So I think the only anatomy, favorable or unfavorable anatomy, is the target to not to use or to use possible, not the bleeding risk. Bleeding risk.
আরেকটা জিনিস স্যার যেটা বললেন, if the patient is on low molecular weight heparin, most of the patient of us with non-STEMI used to get the low molecular weight heparin. In that patient, if we stop the low molecular weight heparin at morning dose, usually we omit, then we give the heparin. But the guidelines said there is no need for loading heparin during procedure like this. Yeah.
No. Guideline বলেছে যে if the IV দিতে হবে তোমাকে Enoxaparin, not an unfavorable, but তারা কিন্তু একটা মানে বেশ সারপ্রাইজিংলি দে হ্যাভ গিভেন অল দ্য অ্যাটেনশন টু fondaparinux, not Enoxaparin. মানে if you are using fondaparinux, then you can give loading dose unfavorable, but if you are using Enoxaparin, you should give IV Enoxaparin during PCI, not
fondaparinux। কিন্তু স্যার 8-10 বছর আগে খুব পপুলারলি এরকম ভাবে এক্সটেন্সিভলি অনেকে ইয়ে করছিল,
আসার পর সে হারিয়ে গেছিল,
8-10 বছর কিন্তু
তারপর আবার আসছে came back again.
এবং এবার একমাত্র ইউজ হচ্ছে হিট। হেপারিন ইনডিউস থ্রম্বোসাইটোপেনিয়া যদি কারো ডেভেলপ করে, এইটা একটা, আর এটা হচ্ছে যদি রেনাল ইমপেয়ারমেন্ট কারো আছে, তাহলে fondaparinux ড্রাগ অফ চয়েস রাদার দ্যান enoxaparin। আর ম্যাডাম যেটা বলছেন, ম্যাডাম আমরা কি তাহলে আইভি লো মলিকুলার ওয়েট হেপারিন ইউজ করবো ক্যাটলেবে লোডিং ডোজ হিসেবে পিসিআই এর আগে?
No, Professor Rahiduzzaman told us that this is in the guidelines. I think the professor, but remember when first enoxaparin came in Bangladesh, that was like 20 years ago, I think, and they did this study. I don't know whether Professor Rahiduzzaman remembers it or not. They advocated IV enoxaparin, and they were doing this global study, and we also gave it, and the results were quite good actually. I mean, we didn't have any complications. Do you remember, Professor Rahiduzzaman? Like,
yes, but actually I think just a practice. We don't use it, we don't practice it, otherwise it's not a very we can use
yeah, because it was absolutely all right. We were giving IV enoxaparin, and they had conducted this study. It was ages ago, and I think the results were quite satisfactory for them, and maybe some other studies have gone, and now they're again propagating this. So great discussion, and we can go on forever, I think. It's a never-ending discussion. These are very topical things and very interesting to know. And so I would like, I think, in the interest of time, like to conclude the session now. I would like to again thank our speakers and all our panel of experts, and especially our guest, Professor Romol, for giving us his valuable time. Thank you, Professor Rahiduzzaman. Great presentation, and
Thank
great presentation, Smita. So with that, I would like to say good night to all of you.
Thank you. Thank you. Good night.
Good night.
Thank you, ma'am.
Thank
Thank you, sir.
Thank you all to all.